Hi, my name is Erica Koopmans. I'm a graduate student working with Dr. Quinn Doan, an emergency pediatrician at BC Children's Hospital and a clinician scientist with the BC Children's Hospital Research Institute. I am here to walk you through HEARTSMAP on behalf of Dr. Doan and Dr. Tyler Black, the medical director of the Children and Adolescent Psychiatric Emergency Unit at the BC Children's Hospital. Over the last several years, with the emergency department overcrowding becoming increasingly more prevalent, Dr. Doan's work has focused on developing new models of care to improve outcomes for children and youth. Despite the fact that mental health has garnered a lot of attention in the media, each year more children and youth seek support in the emergency department, and based on current evidence, these patients are not getting the help they need. The objectives of this video are to cover why HEARTSMAP came about, what is its purpose, what is HEARTSMAP itself, who is HEARTSMAP designed for, and how to actually use the HEARTSMAP. Mental health problems among children and youth are now recognized as a significant burden at the population level. In Canada, 14 to 25% of youth are affected by at least one diagnosable mental health disorder. In a classroom of 30 students, this translates to about 4 to 7 children per class, struggling with a disorder significant enough to impair functioning in peer relationships or expectations at home and school. With community-based resources becoming increasingly difficult to access, 75% of youth will not receive timely mental health care. Unfortunately, the first contact with the healthcare system for most of these youth is through our emergency departments. From 2002 to 2012, the volume of mental health visits at BC Children's nearly doubled from 529 visits in 2002 to 983 in 2012. As you can see on your right, youth presenting to the BC Children's Emergency Department with a mental health complaint consistently had extended lengths of stay compared to their non-mental health counterparts. Psychosocial assessments require a fair bit of information sharing, and as the majority of mental health visits occur when the patient is experiencing an acute crisis, families are often unable to accurately provide the clinician with relevant information. A psychosocial assessment is a necessary step in assessing a psychiatric emergency, but they can be time-consuming and are heavily reliant on information sharing. Emergency department clinicians often struggle to obtain this information or access it from another source. This makes it difficult to coordinate follow-up care, which perhaps explains why almost a third of our mental health presentations were return visits. While we all recognize that the mental health system is fractured and in need of review and upgrade, and that access to services remains a challenge for many youth in BC, we also have to acknowledge that as emergency clinicians, we have an important role in the changes that are required to arrive at the ultimate system improvement. It is true that we have little impact on access to non-acute and non-emergent psychiatric services, and should not be expected to diagnose nor treat or eliminate chronic safety risks. However, it is within our power to efficiently, reliably, and accurately identify the mental health resource needs of youth who seek care in the emergency department, and it is our responsibility to guide families towards the right type and level of mental health services in the community. HEARTSMAP is a standardized and tested emergency psychosocial assessment and decision guiding tool, which will help us to optimize our effectiveness in managing pediatric mental health presentations in our emergency department. Emergency physicians are commonly primarily preoccupied with the risk of suicide among youth brought to the emergency department, leading them to forego a comprehensive but efficient psychosocial assessment to address the underlying cause for the emergency department visit. I'm not saying here that the self-harming behavior or the suicidal ideation is not important. What I'm saying that it is often a chronic risk and the acute issue bringing the youth into the emergency department, which actually needs to be addressed, may be something else than the acute safety risk. To illustrate this, here is a table showing the risk of suicidal death among patients who were seen in a tertiary care emergency department in New Mexico over a 10-year period. The key point here is that the risk of suicidal death at 1 year after the emergency department visit is 2 per 1,000 among male youth with a history of suicidal ideation, self-harm, or overdose. These increase to 1.1% at 10 years. Among females, the risk is much lower, only rising to 1 per 1,000 at 5 years post-emergency department visit. So the bottom line is, The risk of suicidal death among youth seen in the emergency department with suicidal ideation, self-harm, or overdose. These are mostly long-term risks and not the only thing to consider when a youth is brought into the emergency department with a mental health crisis. So what is HEARTSMAP, beyond a quirky acronym? HEARTSMAP guides the emergency department clinician through a psychosocial assessment, collecting information across 10 mental health sections: home, education and activities, alcohol and drugs, relationships and bullying, thoughts and anxiety, safety, sexual health, mood and function, abuse, and professionals and resources. These 10 mental health sections map to at least one of 5 domains: social, function, youth health, psychiatry, and abuse, which are linked to specific recommendations for management. The HEARTSMAP can be done quickly and can help organize the complexity of a psychosocial assessment. HEARTSMAP is hosted on an online platform. As long as your device is connected to the Health Authority network, you will be able to access the tool. HEARTSMAP is designed to help clinicians conduct and organize their psychosocial assessment. Using information provided by patients and their families, the clinicians are able to use the tool to enter their assessment notes, allocate a score for the severity of any highlighted concerns, and indicate whether the family has any services or resources in place to address any issues. After completing the assessment, HEARTSMAP provides an individualized list of recommendations for management specifically to support the family's most urgent needs. Each section, as demonstrated above, has sample questions to help the clinician engage with the youth and family, a place for the clinician to enter in their assessment notes and provide justification of their scoring, a severity score with accompanying criteria, and a radio button to indicate whether the patient has resources in place to address the identified concerns. After completing the assessment, HEARTSMAP generates a report that provides the clinician with an individualized management plan tailored to the patient's needs. As I've alluded this far, HEARTSMAP is designed to help emergency clinicians in the conduction of their pediatric emergency psychosocial assessments. The emergency clinician tasked with doing the assessment varies from site to site. Where available, a psychiatric liaison nurse or a dedicated mental health worker may use the HEARTSMAP to conduct their assessment. Alternatively, emergency physicians may be the ones conducting the emergency psychosocial assessment. In academic centers, trainees are given the paper version of HEARTSMAP to collect required information, which can be used to score the HEARTSMAP online when reviewed with the supervising physicians. At the BC Children's Hospital, social workers and emergency nurses are also trained in HEARTSMAP, and upon completing the HEARTSMAP would review the disposition plans with the emergency physicians. HEARTSMAP is accessible online, and theoretically, the psychosocial assessment could be completed live while gathering the information using a mobile device. However, in Dr. Doan's experience, which is corroborated by youth involved in HEARTSMAP implementation, typing while interacting with youth and their families is disruptive and impedes sharing of sensitive information. Rather, Dr. Doan prints out the paper version, which can be found in the resource section of heartsmap.ca, and writes notes while conducting the guided interview. Using this process, Dr. Doan finds scoring and documenting of the assessment online much more thoughtful when leaving the patient and using HEARTSMAP from a desktop workstation in the emergency department. Upon completion, the HEARTSMAP report, which contains all your assessment notes, along with consulting and referral recommendations, can be printed. If completed on a mobile device which cannot connect to a hospital printer, the report, which should not contain any personal identifiers, can be emailed to your work email address to be accessed from a desktop for printing and incorporation to the youth's health records. To show you how to use the tool, we will walk through an example case reviewing how each section is scored. The fictional case is of Nevaeh, a 15-year-old female brought in by parents at midnight when a friend alerted them of her posting on social media that she hated her life, along with images of cutting marks on her forearm. When you go to heartsmap.ca, after completing registration, you'll be able to access the tool from any computer connected to a health authority network. Other features of the website, such as resources and registration, can be accessed from any computer or network. When logging into the tool, you will be directed to this page. Here you are required to provide some demographic information on the youth you're assessing. In the case of Nevaeh, we'll enter in 15 years for her age, and according to the triage assessment, had a score of 3 on the Canadian Triage and Acuity Scale. Assuming that the family informs us that they have not sought mental health care within the past month at any emergency department, we click No and move on to the next page. Through questioning and using some of the sample questions, we learn under Home that Nevaeh lives at home with a reconstituted family, including her mom, stepdad, and 2 stepsisters. She hasn't been getting along with her family and resents her mom for not taking her side when she's arguing with her stepsisters. While the family is trying to support her, she feels isolated and lonely, and the family is feeling increasingly helpless. They have not yet accessed any resources or external help to deal with their family struggles. In this case, as the family is moderately stressed and at risk of burnout by Nevaeh's mental health status, which is confounded by the frequent conflicts, I would score the home situation a 2. A score of 0 would be that both parents are fully supportive and there are no significant conflicts. By conflict, we are not talking about usual parental-youth discord over family rules and chores, which are about the youth's best interests, but rather arguments that are born from either the youth's mental health conditions or the family's own psychosocial struggles. A 1 would be that the family is supportive, but there are minor conflicts. For example, occasional trivial arguments about non-chronic points of disagreement. A score of 3 would be that the parents are burnt out, can no longer tolerate the patient, or the home situation is so dysfunctional that is seen to be the root cause of her mental health problems. Because a score is greater than 0, the clinician should ask if the problem has been addressed and if there is a plan or resources in place. Note, the resource does not need to be accessible 24/7, but within reasonable time periods. In this case, we learn that the family has not yet been connected to any social support or family counseling, so we would indicate that social supports are not yet accessed. The next section is education and activities. Here, the parent tells us that Nevaeh has good school attendance with stable grades. Nevaeh herself feels happiest at school despite the stresses associated with schoolwork, as that is where she accesses her social support network. Looking at the scoring, she has been maintaining average grades and has been attending school regularly. Thus, there is not specific educational concerns. I would score a 0 here. Had she been having difficulty maintaining average grades, attends more than skips classes, but has been missing the occasional classes due to psychosocial issues, we would score her a 1. A score of 2 would be that the patient's grades are slipping. For example, she used to be a straight-A student and is now unmotivated to do better than average, or she is missing more than half of her classes. A score of 3 would be a patient who has completely dropped out of school or will not be progressing to the next grade. Here, because she has no specific educational issues, we would not be required to assess the resource status. For any other score, the involvement of a school counselor, the presence of an individual education plan, or school staff support would be considered as available resources in place. Under the next section, alcohol and drugs, we learn that the patient denies alcohol or drug use, so this is a fairly straightforward evaluation for her, and the section would be scored a 0. And thus the resource section would not need to be scored. A score of 1 should be given to youth who use substances infrequently and recreationally, for example, at some parties or the occasional event. A score of 2 should be given to youth who use substances recreationally but regularly, or for those who are experiencing mild deleterious effects of their substance use, for example, being brought home by the police intoxicated, or missing school because of a hangover. A score of 3 should be given to youth who use substances to significant detriment, either binging, which can be dangerous, or outright substance abuse that causes major dysfunction in their life. For relationships and bullying, we learn that Nevaeh has healthy relationships at school and has relied on them for support, and they are the ones who alerted the family to her threat to safety. Given this scenario, I would score the relationship section a 0, as there are not concerns with her ability to create or maintain healthy relationships. We would have scored her a 1 for relationships if she was struggling to maintain her friendship due to lack of interest in spending time with them, or was also starting to have some conflicts with them as a result of her moodiness. If she had stated that she was bullied, or was feeling depressed from lack of friends, or cutting more because of her relationship issues, she would score a 2. A 3 would be a patient who stopped any activities and is now a loner, cut off all social interactions, or if her relationship was dysfunctional, as in the relationship is contributing to the mental health deterioration. For thoughts and anxiety, the sample questions try to elicit a history of any anxiety, hallucinations, and delusions that may exist. For Nevaeh, she denies hallucinations or delusions. While she sometimes worries about the future, she has not had any anxiety symptoms which affect her routines or daily activities. She's not happy doing activities involving her family, but this is not related to anxiety or concerns. Under the scoring category, we should document and consider both anxiety and thought problems, scoring whichever is worse. Since she doesn't have either thought or anxiety issues, we'll score her a 0. Should there have been some mild thought or anxiety issues, such as some odd obsessions or occasional panic attacks which have not prevented her from going about her usual activities, we would score her a 1. A score of 2 would indicate obsessive thoughts or compulsions, or anxiety that regularly impedes her ability to pursue activities of daily living. A score of 3 would indicate severe anxiety that limits her ability to function. For example, stopping her from going to school, attending any activities. Severe anxiety may also interfere with her getting the help she needs, such as making it to therapy or doctor's appointments. Command hallucinations would also dictate a score of 3 in this section. Under safety, the clinician is trying to assess Nevaeh's suicidality or safety risk to others. She gives the following information. While she's been entertaining the thought of dying and is quite unhappy with her current living situation, she's adamant that her self-harm is to relieve her distress and not with the intent to cause her death. She has no intention to end her life, nor does she have plans as to how she'd pursue that. In the midst of arguing with her stepsister, she's yelled threats at them, but has no intention or plans to hurt them. Nevaeh also confides that when she thinks of death and dying, she texts her friends who usually cheer her out of it, or she trusts that they would get her help if she was getting worse as they did tonight. In this scenario, Nevaeh's safety situation is consistent with a score of 1, and she has a safety plan in place that is consistent with her previous level of safety risk. A score of 0 is straightforward. There are no safety concerns with respect to self-harm, suicide, or aggression. For moderate concerns, or a score of 2, a patient would present with passive suicidal ideation. Passive suicidal ideation is thoughts about suicide that do not have any accompanying plan. For example, the statement, "I really wish I was dead sometimes. Perhaps I'll starve myself to death." Alternatively, is a youth who says, "Yeah, I might do something to hurt myself. I don't know." We would assign a score of 3 or major concern for safety when a youth is actively suicidal with a realistic and accessible suicide plan. For example, the statement, "I am going to die. Once I leave here, I'm going to the nearby bridge and will jump off it." Severe safety concerns also include practicing behaviors such as holding a handful of medication in their palm or holding a rope around their neck to see how it would feel. Similarly, significant attempts that could be lethal, such as overdoses or hanging attempts, or gestures that are sufficiently dangerous, such as gesturing on a 10-story balcony, would be scored as a major safety concern. Moving on to sexual health, Nevaeh says she is not currently sexually active and broke up with her boyfriend when he was pressuring her into activities she wasn't comfortable with. A score of 1 would be appropriate to designate a youth who is sexually active but is taking appropriate precautions both from a family planning and sexually transmitted disease perspective. A score of 2 would be assigned to a youth that is sexually active but not consistently practicing safe sex, whether due to lack of awareness or psychosocial issues. A score of 3 would be assigned to a youth at high risk of unplanned pregnancy and/or sexually transmitted diseases. This could be a youth who engages in unprotected sexual activities with multiple partners of their own volition, or in the context of maintaining their recreational drug habits, or as a result of frequent intoxication. Under mood and behavior, we learned that Nevaeh has 6 months' history of feeling depressed with irritable mood, poor concentration, low energy, and poor sleep. While her eating seems to have changed, she hasn't lost any visible weight. A family doctor was notified, but he recommends that they hang tight and give her more time, or if things didn't get better, to go to a CYMH team and get her assessed there. The family, not being familiar with this and being worried about this new awareness that she had been cutting, went straight to the emergency department. Here, she would score a 2 for her long-standing depression with ongoing symptoms. As Nevaeh has never been assessed nor received any care for her mood issues, we also note that no resources have been accessed yet. A score of 1 would be a patient who has demonstrated some adjustment difficulties and few behaviors suggestive of poor coping, but that are self-limited. A score of 3 would be if the patient had depression symptoms that are affecting her activities of daily living or affecting her physical health. In terms of functional issues, we are looking at unhealthy or behavior showing dangerous disregard for self, and inability to maintain basic activities of daily living, such as excessive sleep, extreme eating behaviors which is affecting her body weight, or with measurable physiological changes. For abuse, she denies she has received any abuse and would score a 0. Note, the scoring here is different. A score of 2 indicates abuse that is remote or has been reported. For example, a child who has already received protective services from the ministry. It can also be used for a child where there is a concerning situation that has not crossed the line into abuse, such as a significantly older significant other or a parent who is becoming increasingly conflictual. A score of 3 indicates any report of abuse that has been shared with the clinician when it has not been addressed. For example, a child who shares that their mother pulls their hair and slaps them, or a concerning hand-shaped bruise on the arm. Nevaeh's family involved the family doctor about her mood a few months back, but have otherwise not taken any other steps towards addressing her mood issues until tonight. Given this information, for this section she'd score a 3, as she has not yet been assessed and no service plan is yet in place. Note that this section only has 3 options. A youth either has all the referrals and has initiated access for the resources they need, excluding imminent safety issues, or is on a waiting list, or have no access, whether that is due to a lack of referrals or to poor adherence to the resource. So to reiterate, the second box would be selected if someone is aware of her problems and have referred her, but she has not yet had help. The third box is for any major concern with professionals and resources. Examples would be a patient presenting with alcohol overdose, but refusing any help in the community, or a patient that has been rejected from a mental health team, but clearly has mental health needs. All youth who have yet to be referred or are new to service should be scored in the third box. On the last page, the clinician is provided with a list of disposition options. This is to gauge how the clinician's own impressions of the youth's needs align with the tool's recommendations for management, and if this changes over time. The clinician's recommendations for management will not be included in the generated HEARTSMAP report. So in this case, considering Nevaeh's most severe issues are chronic and her acute concerns, specifically cutting, is not suicidal, thus her safety risk is mild, Dr. Doan's impression would be to redirect the family to their local community child and youth mental health team through a walk-in assessment for access to care. Once the clinician has made their selection, they can hit submit. On the last page here, you'll see that all of the assessment notes and the recommendations for management are summarized. A report can be either printed out for sites using paper-based charts or attached as a PDF for sites using electronic medical records. The reports have been individually customized to comply with health authority-specific standards so that they can be included in the patient's medical record. Note that the report is not yet labeled and should not contain any personal identifiers. Patient identification and labels need to be added by you to the form in order to link it to the patient's file. There is the option to email the unidentified report to yourself as well. We've enabled this feature to allow clinicians to access the HEARTSMAP tool from a personal electronic device, such as an iPad or tablet, and print from a hospital computer connected to the department's printer. Please note that the report will be emailed to the work email address you provided during your registration. Going back to this example case, I'm going to select BC Children's Hospital from the top drop-down menu and click Download Report to print. This is a report customized for the BC Children's Hospital Health Records requirement, but your report will be customized for the site where you're using HEARTSMAP, and it can be included in the paper chart or scanned into your electronic health record once identified with the patient's labels. Thank you very much for learning about HEARTSMAP. Should you have any questions or technical difficulties in accessing the tool, please do not hesitate to contact us through the Contact Us link at heartsmap.ca.